So the slow and often asymptomatic nature of glaucoma presents many challenges during our examination and diagnosis. So this session deals with the common dilemmas in glaucoma and hope it will be helpful for you in your clinical practice. So the first presentation, I invite Dr. Smita to present on cup disc IC glaucoma. Over to you, Dr. Smita.
Thank you, KSOS and Dr. Gijja for giving me this opportunity. My topic is cup disc IC glaucoma. Cupping is described as an enlargement of the cup to disc ratio. It's a well-known feature of glaucoma. Diagnosis is easy when the IOP is high and there is glaucomatous cupping, but it becomes a problem when the IOP is normal and there is cupping. 20% of non-glaucomatous conditions are misdiagnosed based on large cup disc ratio. The typical features of glaucoma are enlarged vertical cup disc ratio. The inter-eye cup disc asymmetry is more than 0.2. Normally, in the optic disc, the Ising rule is obeyed. That is, inferior rim is thicker than superior, then nasal, and thinnest is temporal. While in glaucoma, this is violated. And there will be focal or broad notch. Disc hemorrhages can be seen. This is more commonly seen in normal tension glaucoma. It is seen more in the inferior or superior rims and is usually perpendicular to the disc. And RNFL defects, which are wedge shape, which extends from the disc and spans out peripherally, is common in glaucomatous condition. If there is any cup disc ratio asymmetry in both eyes, we have to assess the disc size. In this patient, the left eye has more cup disc ratio, but the left eye disc area is more. The conditions that can mimic glaucomatous disc cupping are congenital conditions like tilted disc, optic disc glaucoma, optic disc peaked, morning glory anomaly, neuro-ophthalmological disorders like intracranial tumors, hereditary optic neuropathy, ischemic optic neuropathy, toxic nutritional optic neuropathy, high myopia, optic neuritis, and retinal diseases like RP, BRVO, CRVO, etc. In optic disc glaucoma, you can see a clearly delineated wide bowl-shaped excavation with thin or absent neuroretinal rim, and the blood vessels originate from the periphery of the excavation. Here there is an inferior excavation with a corresponding superior field defect. In optic disc pit, you can see a large disc with grayish round or oval pit. The pit is usually temporally located with temporal pedipapillary atrophy, and OCT can show neurosensory detachment. In morning glory anomaly, there is a large size disc with a central glial tuft. There is increased number and radiant blood vessels emanating from the central glial tuft. And there is annular pedipapillary chorioretinal atrophy with corresponding enlargement of the blind spot. In superior optic nerve hyperplasia, otherwise known as topless disc syndrome, there is pallor of the superior optic disc with pedipapillary scleral halo and thinning of the superior RNFL with corresponding inferior visual field defect. The central retinal artery has a relatively superior entrance to the eye. In megalopapilla, there is a large optic disc with large cup. There is no neuroretinal rim thinning or visual field defect. In high myopia, the disc can be large with more shallow and thinner cup, shallow cup with thin neuroretinal rim. The disc may be tilted with pedipapillary atrophy. Visual defects can mimic that of glaucoma. That is, there may be a large blind spot caused by the large pedipapillary atrophy, arcade scotomas by tilted disc, and paracentral scotomas due to chorioretinal scars can be seen. In retinitis pigmentosa, there is diffuse waxy pallor of the disc and the cup is not well delineated, and there is vascular attenuation and bony spicle pigmentation. In CRVO, there is diffuse pallor of the disc, and BRVO and BRAO, there will be localized pallor and cupping with associated no fiber layer defect. Intracranial tumors like chiasmal and pre-chiasmal tumors can have optic nerve changes. These include pituitary tumor, craniopharyngioma, optic nerve sheath meningioma, etc. Here, pallor of the rim is more than cupping. Detailed history, age of presentation, loss of central visual acuity, color vision defects, RAPD, field defects respecting vertical meridian, and neuroimaging helps us to get into diagnosis. Here, this is a patient with pituitary adenoma with bilateral disc pallor, and there is no PL in the left eye and right temporal hemifield defect in the right eye. In optic neuritis due to multiple sclerosis, there is temporal disc pallor and relatively good visual function. Central scotoma may be seen in HFA. And in neuromyelitis optica, there is marked disc pallor and subnormal visual function. In hereditary optic neuropathy, there is temporal disc pallor with central or centrocecal scotomas. In non-arteritic anterior ischemic optic neuropathy, there will be sectoral disc pallor associated with retinal blood vessel attenuation. And the fellow eye has a small disc or disc at risk. In arteritic ischemic optic neuropathy, there is moderate increase in cupping and diffuse pallor. Nutritional and toxic optic neuropathy, they are usually bilateral with color vision loss out of proportion to the central vision, and temporal pallor of the disc is seen. The papillomacular bundles are usually affected first. In traumatic optic neuropathy, there is gradual increase in optic disc cupping, temporal pallor, and mild attenuation of blood vessels can be seen. Glaucoma can coexist with this condition. So, glaucomatous optic neuropathy is seen more commonly seen in aged patients, while non-glaucomatous optic atrophy is seen in young people. And central visual acuity is affected early in case of non-glaucomatous optic neuropathy, while it is spared till end stage in glaucoma. And RAPD is seen early in non-glaucomatous disease, while in advanced cases in glaucoma. And pallor more than cupping is a feature of non-glaucomatous optic neuropathy, while in glaucoma, cupping more than pallor is seen. And wedge defects more commonly in the superior and inferior vascular arteries are seen in the glaucomatous optic neuropathy, while NFLD more common in the papillomacular bundle in non-glaucomatous optic atrophy. Field defects respecting horizontal meridian is seen in glaucomatous optic neuropathy, while field defects respecting the vertical meridian is seen in compressive optic neuropathy. And glaucomatous optic neuropathy is usually bilateral, while non-glaucomatous optic atrophy is usually unilateral. So in conclusion, glaucoma diagnosis should not be based on any single parameter like optic nerve head cupping. The decision making should be based on patient's history, clinical examination, ancillary testing such as visual fields, OCT, and neuroimaging. Thank you.
Thank you, Dr. Smita, for that wonderful discussion on the common dilemma that presents to every ophthalmologist. Now I invite Dr. Jayasree to talk on high IOP and open angles, lasers or drops.
So, good evening all. At the outset, I would like to thank KSOS and Dr. Girija for the opportunity. And this is a common dilemma whether high IOP and open angles needs to be treated with lasers or drops. Let's see how it can be done. I do not have any financial interest in the presentation to be made. For a treatment success, we need all these 4 pillars. The compliance of the patient, safety of the treatment, quality of life should not be compromised, and there should be glaucoma control. Our toolbox is expanding not with respect to glaucoma medications alone. More and more methods of treatment are also evolving. We know that when we use medications, there are multiple factors that affects the compliance of the patient. The dosing schedules, cost, side effects, and all those has to be considered. And also the patient forgetfulness, cost, and other diseases, all those comes to play. Along with that, the ocular IOP fluctuations has to be remembered, because that is what leads to progression of the disease for the same IOP. This appearance that we see on the right side is not uncommon. We come across patients with these similar features in our OPD, and OSD is a very common problem with ocular medications. Patients with dry eye and in varying manifestation is very common. So that with all this, considering all this, the adherence to treatment and persistence of treatment is always compromised. At least it is seen that 90% of the patients becomes non-adherent at one point or the other. So this is where the laser treatment becomes important, and it reduces the burden of compliance from the patient, and the commitment of the patient to treatment is reduced. We are familiar with two types of laser. The earlier one, which was the ALT, which produces the coagulation and scarring of trabecular meshwork, there is restriction, and the later one, the SLT, which is non-destructive because it produces, it targets selectively the pigmented trabecular meshwork, endothelial cells, and does not produce any coagulative damage, and there are no collateral thermal damage. So even mixed surgery is possible beyond this selective laser trabeculoplasty. So other studies that have shown that the selective laser trabeculoplasty is good as a primary therapy. Earlier itself it was proven that the IOP reduction was there with the initial SLT, 31% IOP reduction was there. How was it performing against the AGM? It was performing equivalent to other medications, especially the PGA was studied along with it. So additional advantage was the need not have compliance, and the side effects were not there. Previous studies also looked at the efficacy, which was equal, safety was better, adherence was better, duration, that is like every day you need to put the drops, but the SLT has to be, if at all, repeated as and when required. The cost definitely, because of the recurring use of medication, was much more. So, but all this never changed our practice pattern, even though we came to know that SLT was effective. What was that milestone study that affected our thinking process? It was this study, the LIGHT study, which is the selective laser trabeculoplasty versus eye drops as a first line treatment for ocular hypertension and glaucoma. It is a very well done study, multi-center randomized controlled trial, which looked at the primary outcome being the health-related quality of life and the cost effectiveness, and the secondary outcomes like IOP control, disease control, need of surgery, and patient without medication. And there was an that was a 3-year study, and then there was an extension of 3 more years, and again this was with high retention rate of 82%. So one wing had lasers, one wing had eye drops, and the endpoint was reaching the target IOP. Initially, the health-related quality of life was the primary outcome, but quality of life was similar, maybe because these patients who are on SLT never actually had the experience, the bad experience of using medications. And when we come to the IOP reduction, up to 8 millimeter was reduced in the initial 2 months. And when we see the percentage of eyes at target IOP over time with just lasers were as high as these values. And these are the severity of glaucoma, and you can see that the maximum reduction used to happen for the ocular hypertension. So this is a comparison. You can see that the SLT performed better with all the important parameters when the disease progression was less, cataract surgery was less, there were no trabeculectomy that was required, eyes at target IOP was better, the escalation of treatment was less, adverse events were less, the drops free at 3 years. Patients, 75% of the patients were drops free after an SLT at 3 years. So this slide also shows the same thing. The cost effectiveness is one thing that was very important and has more of a community aspect also. But what happens when the study is extended for 6 years? The same thing is shown on a magnified level. The disease progression is further, the gap is further seen. Trabeculectomy surgery again is much lower. Cataract surgery is lower. The drop-free target of drops-free and target IOP was up to 70%. Even at 6 years, 70% of the people were without medication. And eyes on single medication was like 1+ medication was 18.5%. So again, this is the comparison between the two eyes. The most important thing was progression was less with the SLT group, even for the same IOP that was reached. So does the repeat SLT help if the patient has higher IOP or the target IOP is not reached? Does the repetition of SLT help? Definitely, the repeat SLT help even if it is a late failure or early failure. And not only this study has shown, the previous studies of repeat SLT has shown effectiveness of the procedure. And then there are studies like COST study, which shows that repeatedly every year, if you are doing small SLT in lower strength, that is also on the way. And this study has become a game changer. Why? Because the ophthalmological societies have incorporated and has mentioned that this has to be considered. The SLT has to be offered to the patient when the patient comes to you and you detect the primary open-angle glaucoma or ocular hypertension. You are bound to tell to the patient that we have a choice, not just glaucoma medication. You also have a choice of SLT as treatment for glaucoma. So why are we still hesitant about not taking up this procedure? From the patient side, if we are all starting medications, it is very much acceptable. Patients are aware about that. But the moment when you say a procedure, that hindrance comes from the patient side. But you have to reassure the patient, because it's not it's a very safe procedure, and you get, as we could see, 6 years of 70% success. But from the ophthalmologist side, the one thing is availability of the machine. Second is the initial investment, learning curve. You have to identify the properly, because anybody can just write a drop but not identify the gonioscopically identify correctly. And procedure time is required. You have to get up from the OPD and go and do the procedure. Lack of awareness. The effectiveness is not known to anybody, not many. The follow-up is still important, because once you start the medication, once you do the laser also, you cannot send off the patient. You can still have to remember to call the patient, and patient also has to remember that they are glaucomatous patients. Another one is DSLT, which is very important, because that time from the doctor's side is removed, because it is an automated procedure. So you have seen that there are so much of changes from the side effects process, and all this is negated. And do we still have this dilemma? But when we come to India, that level of success is not seen. So that is why the dilemma still continues. Thank you.
Thank you, Dr. Jayasree, for that excellent presentation. Now I invite Dr. Satyan to present on established glaucoma, drops, mix, or trap.
Thank you, Dr. Girija, and thank you for this wonderful opportunity to be with you all. Dr. Jayasree, do you do SLT routinely in your eye vision center? So availability is an issue. In spite of you being a glaucoma person, Anup is not willing to give you one. Okay, so let's see why. So how many of you are really willing to do SLT here? Is it that you are convinced with her talk? How many of you are really convinced with the talk, saying that SLT is a better option than your medications? Only one? Okay, two. So, okay, so it is important that whatever she has presented is true, and then we have been doing SLT for several years. In primary open-angle glaucoma, provided that you have done a proper gonioscopy, primary open-angle glaucoma, do SLT, it really does very well. So in case if you want to really invest in, it is not a bad investment, provided that you have an adequate number of cases to be done. So let's see the established glaucoma. I don't have any financial interest for this particular topic. So you do all this before you really just establishing a glaucoma is the most simplest thing in today's practice is IOP, fundus change, glaucoma. So that is not the end of the story for you to treat glaucoma. It is much more than that. Please understand, you have to take a detailed history, proper ophthalmic examination of all that, and you need to have the CCT, OCT, fundus photography, and the visual fields. It is no more just that you have to do it for glaucoma patients. It gives so much of an information. Is it glaucoma? Is it not glaucoma? Does the patient have any risk factors? Is the patient progressing? Or is the patient having any other associated illness? So for all this, you need to have all this fundus photography and other investigations like OCT, fields and other things. So the second factor is, once you establish the glaucoma, then you need to understand what is the stage of the disease that patient has and what is the patient's preference. How many times have you ever asked the patient, are you willing to use the medication? Just, we are all only the masters. We don't listen to you. We say what you should do. Are we not really too rough to the patients? We never consider the patient as a patient or a human being itself. We say, I tell you do this, that's it. So that is why we have a poor follow-up rates and also poor compliance as well. We don't know how much is the tolerance and other things. So once you really kind of establish the glaucoma, so there is a broad guidelines I am giving you here, like IOP of less than 30 or 35, where the medication can really work. If anything more than 35 or so, the medications, single medication may not really work. That is the basic concept that I have given you here. So if it is over 35, then you treat with your Diamox and other methods, then bring it down to 35. So once you have brought it down to 30 to 35, below that range, then you have the options of, you have a medical, you have the lasers, then you have the mixed procedure, then you have the trabeculectomy. So once you have the disease as mild to moderate, how many times you have done the staging of the disease in your practice? Have you ever done that? If you have not done, please start doing it from today. Do the fields, do the OCT, do the fundus photography, understand, make sure that then comes your MAGS or the trabeculectomy option as only as the secondary options. It is not going to be your primary choice ever. So looking at the medications, it is always our first choice in our practice. Once you diagnose the patient as a primary open angle glaucoma, then you have the choice of both medical as well as the SLT as the primary choice, first choice itself. Medication is definitely non-invasive. It is titratable. Then it brings down the IOP to a very critical, whatever the levels that we are kind of expecting. So all stages of glaucoma it works, and any type of glaucoma it really works. And so that is the reason why we all start with the medications. But once you expect the patient to be going to be very poor compliant, so I was just telling George that in our own population, the compliance of our medical management is after 1 year is only 20 to 30%. The 70% of the patient, they don't apply the medications. So how many of us have realized that? Most of us have not realized that. Even though we have realized, have we changed our pattern of treating the disease? We have not changed our pattern of disease because we are arrogant. We just follow what we feel that patients should follow. So that is not a good idea. So SLT definitely has a role to play in all our practice. But for doing SLT, you have to start practicing your gonioscopy. You must do gonioscopy in every given patient. If you don't do the gonioscopy and if you're going to diagnose the patient as a primary open angle glaucoma, you are at 100% fault. As an Asian country, we do have equal number of angle closure disease. So you must understand this. So doing SLT is good, provided that it is only a primary open angle glaucoma. So SLT works perfectly well, 360 degrees. It is not that, okay, you do 50% today, the remaining 50% later. It is not so. You got to do 100%, one full 360 degrees you have to do to get the results. SLT can be repeated and it gives you decent results. It is equivalent to 1 PG analog, where it can reduce to 30 to 35%. And the progression, what we have seen in the post SLT eyes is very, very less. The reason is the fluctuations are lesser. The medication group, always the fluctuations are higher. That's why you tend to see the progression happening in the medication group. So then we have the secondary option as MAGS, because it is catching up much faster than what we all have expected. It is much, much faster. If you really look at Arvind, also each center has, of course, the different levels of MAGS procedure done. Tirunelveli has the highest, I think. Then comes Madurai, Tirunelveli, Coimbatore and other centers. So MAGS definitely, as of today, we are going to focus only on the mild to moderate glaucoma because it has its own set of other advantages in other stages of the disease. But as of today, we keep teaching only it as a mild to moderate disease where you feel the patient's compliance is not good. You can go for it. Or even if the patient says that I don't want to use the medication, you can still have the choice of going in for an MAGS. So that is the best option, but provided that only mild to moderate stage of the disease as of today. Looking at the trabeculectomy, it perfectly works in every given type of glaucoma, every given stage of the disease. But in general principle, we never do the trabeculectomy as a first choice. If the patient's compliance is poor, in spite of using the medication, the target IOP is not achieved, there is a significant progression happening. Then if you feel the stage of the disease is moderate or severe, and if you don't know how to do an MAGS procedure, trabeculectomy is still holds the better, is the best choice because it has the maximum IOP reduction in all kind of glaucomas. So looking at the comparative merits, trabeculectomy holds the highest, then comes your SLT and MAGS. Drugs, quite variable, single drug, 2 drugs. Combinations doesn't work in the same way of what we think all the time. One drug may work for some time, the other drug may work for some time, both can work for some time, both may fail at some time. So it is quite variable. So you'll have to understand there is a stepwise algorithm given, but it is too elaborate a chart that we are going to give it to you when you are coming for GSI at Patna in October, November. Will give you the dates when it is going to be. So this is a chart which you can really use it. You can put it up in your clinic. This is a very, very elaborate chart which we have done. So we'll soon give it to you. So the take home message is drugs works good, but don't be arrogant to the patient. If the patient is not willing to use the drugs, if you have a SLT, that is again the best choice. Start learning your MAGS procedures. It is definitely a way out for mild to moderate glaucoma. TRAB always as a gold standard holds good for all kind of stages, all types of glaucoma. So that is the take home message for this very short talk of 10 minutes. Thank you.
Thank you, sir. That was an excellent presentation. Thanks for the advice on how to behave to the patient and how to proceed with staging and all that. Now I invite Dr. George Puthuran to talk on post-TRAB glaucoma progression. So repeat trabeculectomy or GDD.
Thank you, Dr. Girija, and thank you, KSOS. It's always nice to be back in the home state. So this is a survey by the American Glaucoma Society, where they gave their members a survey about the use of different glaucoma procedures in various clinical scenarios. They did it in 96, 2002, 2008, and finally in 2016. And they found that out of 7 out of 8 clinical scenarios in 2016, GDD, the uptake of GDD was more than a trabeculectomy. In a setting of repeat patient who has had a failed trab, till 2008, repeat trabeculectomy and GDDs were comparable. But in 2016, you can see its GDD has overtaken a repeat trabeculectomy as the procedure of choice in a failed trabeculectomy. In 96, there was not a single response for GDD, but almost 70% of responses were for GDD against repeat trabeculectomy in failed trabeculectomy. So this is a very interesting article about clinical impact of 8 prospective randomized multicenter glaucoma trial. This was also another survey where they independently, this was not the TVT group, they independently concluded the results of the TVT study likely contributed to the shift to GDD rather than repeat trabeculectomy in eyes with previous failed trabeculectomy. As of now, we just have this prospective randomized clinical trial to comment on GDD versus repeat trabeculectomy in a patient who has had a failed trabeculectomy. The study group took patients who have had phacoemulsification and or filters, and then they randomized these patients into one group will get a trabeculectomy with mitomycin, the next group will get a Barwell 350 implant. This is actually the stratum 3 and most importantly the stratum 4 in this group is very pertinent to the dilemma we are discussing today. But the sad part is they had very few patients here to draw conclusive decisions. There are a lot of things which came out of the TVT study. They said tube shunts have a higher success than trabeculectomy with mitomycin. They said tube shunts are associated with a lower rate of early complications compared with trabeculectomy with mitomycin. They said tube shunts have lower resurgery rate when compared to trabeculectomy. I totally agree with this. Tube shunt surgery is less labor intensive. The shepherding required for a post GDD is less than a trabeculectomy. And they also challenged certain established facts. We always thought trabeculectomy got the pressures down to very low teens. In the TVT group, they showed that about 62% of the patients had a mean IOP of 13 millimeters of mercury at 3 years. This is another scenario. It's a phakic eye. Already a trabeculectomy has failed. A second glaucoma procedure is definitely going to induce cataract. There's no doubt about it. So, and there's a lot of literature says that cataract surgery, trabeculectomy, usually the control of intraocular pressure is much less. Trabeculectomy starts failing after cataract surgery. May not be so with tube shunts. We also have published on this a set of patients who had underwent our Orolab aqueous drainage implant. We looked at their pressure controls. Thankfully, it was maintaining even post-cataract surgery. Again, conjunctival manipulation can increase fibroblast production and increase chances of failure. So why again why do a trabeculectomy again in a failed trabeculectomy? So all what I said, it looks as if it's a hands down victory for tubes. But actually that is not the case. That is why we are having this debate. A very interesting publication in which it is written, the tube versus trabeculectomy study, why its findings may not change clinical practice. They have given very clear points to ponder on. They said universally the lower IOP till now the literature says is more with trabeculectomy. High rate of complications in the TRAP group in the TVT study may not be for all others, because the present literature says the complication rates are not as high as in the TVT study. In the TVT study, they used 0.4 milligram ml of mitomycin for 4 minutes in all their patients. There may be motility problems associated with the bowel. Relatively short follow-up. Need longer follow-up to see whether tubes erode in the long term. Every patient in this group had a prior intraocular surgery. They say you cannot extrapolate this to other tube surgeries. And most importantly, as was Dr. Satyan was mentioning, established practice is difficult to change. I looked at literature to search for outcomes of repeat trabeculectomy, and it is sparse. It is not as much as what you would do with what you would get with a primary trabeculectomy or with the tubes. But I found 2 interesting studies. One was this study in which they had almost 75% success, qualified success at 5 years for a repeat trabeculectomy. But I also had I saw a publication, it added more to the confusion I had. Here again, they compared a group of patients who underwent repeat trabeculectomy with an age-matched group which already had an initial trabeculectomy, and they saw that outcomes of repeat trabeculectomy were not as good as the initial trabeculectomy. So this was about 50% qualified success. Much closer home, Shankar Nethralaya group has shown that repeat trabeculectomy with MMC is successful at lowering intraocular pressure and decreasing number of anti-glaucoma medications. And the icing on the cake was my own colleagues in my own department has very clearly written that repeat trabeculectomy with mitomycin used in higher concentration exposure time altered according to individual risks plays a crucial role in the success, and they say you should not abandon this procedure as a viable option before you try a tube surgery. This is a slide which I showed 12 years back in one of the World Glaucoma Congresses, where the same dilemma, we were discussing the same issue. And I feel the only thing that has changed over the past 12, 13 years in this topic is probably the color of my hair. Choice is highly individualized. Most important thing is how long did the first filter work? I think Dr. Satyan always used to tell me more than 5 years is a reasonable justification to consider a repeat trabeculectomy. Your filter has worked for 5 years, it's a reasonable justification to consider repeat trabeculectomy. POEG with failed filter, phakic or pseudophakic, especially if the pseudophakia is a clear corneal phacoemulsification, I would leave it to the surgeon preference and experience with either procedure. Type of glaucoma is a secondary glaucoma with a failed filter, almost always tubes. There's also evidence from the PTV, the TVT and the primary tube versus trap study, which says higher presenting intraocular pressures do better with tubes and lower presenting intraocular pressures do better with traps. I would like to go one stage ahead and say high intraocular pressure, advanced ONH and visual fields, probably tubes may be safer because the risk of hypotony and choroidal detachment and effusions are more with trabeculectomy. Advanced PACG, I will be adding to the confusion here. Advanced PACG, phakic with a failed filter. Believe me, surgeons are tending probably now shifting to mix in these kind of patients only for the safety profile. We don't expect a lot of efficacy in this, but if there's a little bit of incipient cataract, if you can do a mixed procedure with cataract in this setting, aided by goniosynoculasis, probably that would be much safer than a repeat trap or a tube. Again, advanced PACG, pseudophakic with a failed filter, tubes are an option and the pressures are very high. You could try a diode CPC to tamponize the pressure temporarily before going for a tube. I can already see Dr. Girija's IC in KSOS 2227, post-trap glaucoma progression, repeat trabeculectomy or GDD or mix with cataract surgery. TVT study does not demonstrate clear superiority of one glaucoma operation over the other. Believe me, doing a repeat trabeculectomy and getting it to work, I believe needs as much a skill as trying for a tube, as doing a tube, and prefer to use valved implants, non-valved implants, because valved implants are sometimes very unpredictable, and in our hands, these are the scenarios where we prefer a valved implant, NVG, uveitic glaucoma, elderly patient. Thank you very much.
Thank you, Dr. George. Now, I'll be presenting coexisting cataract and glaucoma, trabeculectomy, phacotrabeculectomy or phacoelo.
How many of you are doing a combined surgery here other than CK, sir? None of you? Only 2? 4, okay. So now it is duty of yours to convince and then make them do the surgery. Yeah.
So, very good evening. Coexisting glaucoma and cataract. This is both these are age-related diseases and they often coexist. So, such patients often come to us, and many a times we are at a dilemma to proceed with which procedure. So we have to individualize the case. You have to stage the glaucoma, as Sir has said. Always consider the glaucoma and consider the cataract. Whether the patient requires surgery, that's the first thing. And stage the glaucoma, what's the type of glaucoma, what target you want, the medication burden, and whether the patient is compliant, the status of the optic nerve, the visual field defects, and the cataract's impact on vision. Always consider the comorbidities, the age of the patient, and the affordability, and decide which procedure you want to go ahead with. So this is a 76-year-old man with an NS3 cataract, hypertension, diabetes mellitus, CAD, and the patient has an IOP of 28 and 20 millimeters. So he is a moderate glaucoma with a visual field defect threatening fixation, and he is already on 3 AGM. But he has all the comorbidities and cataract. So glaucoma and cataract with all the comorbidities, 3 AGM and uncontrolled IOP. So how to proceed? So first we will discuss and then we will come back to this case. So phacoemulsification alone is indicated usually in mild to moderate open angle glaucomas and angle closure glaucomas, which are well controlled with anti-glaucoma medications. And there is significant cataract affecting vision. These will result in the phaco will give you a faster visual recovery and there are fewer complications. Unlike trabeculectomy, it may cause a small sustained IOP reduction also when the lens is removed. But you may not get adequate control, especially in advanced cases. And once you have handled the conjunctiva, and especially if a scleral tunnel has been done, there will be conjunctival scarring, and future trabeculectomy may be difficult and the results may not be that good. If you are doing a trab alone, usually it is indicated in advanced glaucoma with minimal cataract where the target IOP is less than 12 millimeters and IOP is uncontrolled even with maximal medical treatment, or in spite of that the visual field is progressing. This is the best IOP lowering potential and it's still the gold standard, but it may accelerate cataract formation. Once you do a trab, the patient is likely to get a cataract at least after 2 years. And a phaco after a trab can jeopardize the function of the bleb. But when there is very uncontrolled IOP, it's always better to do a trab. I will come to later. So phacotrabeculectomy, that these two procedures are combined together in moderate to advanced glaucoma with coexistent significant cataract, and when the patient has a poor compliance or intolerance, and in elderly single-eyed patients where one procedure is preferred, one definitive procedure is preferred. So it can address both the diseases simultaneously and it is convenient to the patient and it reduces the cost, risk of surgery, and multiple surgeries are avoided. And avoid the postoperative IOP spike, which can be due to the retained visco or inflammation or steroid response. So, but technically this is more demanding with more intra and postoperative complications. There is higher inflammation, slower visual recovery, and there may be postoperative complications like hypotony, shallow AC, etc. And this phacotrabeculectomy is less effective in controlling IOP than trabeculectomy. So in angle closure disease, the lens definitely has a causative role. So when lens extraction is done, it can increase the outflow, it can reduce the IOP and improve the visual acuity. This is a meta-analysis of 11 RCTs which showed that phacotrab was superior than the other two surgeries in IOP control, chamber depth, visual acuity and adjunctive therapy. But trab is definitely superior than phaco in IOP control, but it has more complications because most often we are doing it in a eye with a high IOP and we expect a very low target IOP. Now the latest alternative, that is the phaco plus mix. It combines phacoemulsification with mix. The modest IOP reduction with minimal complications and a rapid visual recovery. And mix usually targets the physiological outflow pathways rather than creating an external bleb. So the choice of mixed procedures are there. This is a classification of the procedures. I won't go into that. Usually it is done in mild to moderate open angle glaucoma, pseudoexfoliation or pigmentary glaucoma, elderly monocular patients where safety is more important than IOP drop, and patients desiring medication reduction and rapid recovery, and combine cataract and glaucoma surgery with target IOP less than 18, not when you are expecting a more reduction, like not suitable for advanced glaucoma with target IOP of less than 12. So when a moderate reduction is desired, you can opt for this. It has high safety level, and there is angle anatomy is not that altered. You are directly visualizing it and going with the procedure, and it has got a shorter surgical time. It can be easily combined with cataract surgery because it can be done through the same clear corneal incision. It preserves the conjunctiva, so you can do a future trabeculectomy, and it reduces the dependency on topical medications. So it is an excellent alternative, but it has only a modest IOP reduction. Maximum is 20 to 30%. And there is device cost and availability to be considered, and limited long-term data beyond 5 to 7 years for some of the devices. Now another alternative, though expensive, but with a predictable aqueous outflow, is express shunt, which can be combined with phaco. It is placed, you make a scleral flap, so you create a bleb. You place the express shunt into the anterior chamber. It has an internal lumen of 50 to 200 microns. So it actually, this has a predictable outflow. So it provides an excellent middle ground between high IOP control of trabeculectomy and the safety of mix. And it is indicated usually in visually significant cataract and moderate to advanced POAG or PXFG, which requires a target IOP of around 15 millimeters. And here, patient who need better IOP predictability and fewer postoperative fluctuations, but it has to be affordable because it has a high cost. And conjunctival, those eyes with conjunctival scarring where trab is likely to fail, or eyes with thin sclera, uveitic glaucoma, etc., this may be a good alternative. It has a more standardized aqueous outflow, less postoperative inflammation. There is no iris manipulation unlike in trabeculectomy where you do a PI. Lower rate of hypotony, flat AC, etc., and it has got an often faster visual recovery. And it can be safely combined with phaco. But it has higher cost, and it still forms a filtering bleb. So bleb related complications are possible, and comparable long-term IOP control to trabeculectomy. And it requires mitomycin C for best outcomes. So this is just a summary decision algorithm. Early glaucoma with a controlled IOP with 1 or 2 medications, you can go ahead with phaco alone. That phaco alone will produce some amount of IOP reduction, and you can continue with the 1 or 2 medications. And advanced glaucoma with minimal cataract, always better, or uncontrolled IOP. Then you can go ahead with trab first. Then when the patient develops a cataract, you can do it later but carefully. Significant cataract with uncontrolled glaucoma, go for phacotrabeculectomy, but always expect complications, do it safely. Mild to moderate glaucoma with cataract, it needs modest IOP drop, you can go ahead with phaco and mix. I have not much of experience in mix. I think Sir or Dr. George can say something about combining phaco and mix.
Thank you, Dr. Girija, the IC instructor, has a little bit of a time travel done. We'll have some discussion because we have some 10 minutes or so. So how many of you do the trabeculectomy here? You, 3, 4, okay. So how many of you have the interest in learning the trabeculectomy? Okay. So George is here, Jayashree is here, Girija is here. Every one of them can teach, including myself. So the idea is that we want to move ahead with a lot of training programs from the GSI. So I'm just using Girija's IC as an opportunity for me to say this. So please do learn trabeculectomy. It is not that difficult a procedure. It is still a very good procedure. And it is time for you to learn the MAGS as well to an extent, because we are going to have very, very high numbers of glaucoma patients who needs surgical management. Because medical management, especially country like India or Africa, where the compliance is going to be extremely poor after 1 year, It is not enough for you to just treat the patients with the medications alone. We want you to understand that SLT is definitely a great opportunity that all of you have if you want to practice your medical management of glaucoma, to an extent the laser. Surgical management, it is not that difficult for you to learn. Please do learn at the earliest possible so that most of our own relatives or friends, all their friends, or everybody's eyes can be saved to a great extent, like they don't have to go for a complete vision loss. So I wish that all of you can really do that. If you have any questions, or Dr. Girija and George can add up, or Dr. Jayashree, if you want to add something. So looking at the post-trabeculectomy eyes, the failures, again, it is extremely important to understand if you have an early failure, that is a blood fibrosis is quite fast happening. So these eyes, if we are going to go for repeat trabeculectomy, we are almost sure that it is not going to work longer. So those eyes, it is straightforward answer. Go for a tube so that the patient's survival rate is much better. The surgical success is going to be much better. If it fails later, like 5+ years, then we know it has really worked well. Probably one more repeat trabeculectomy gives definitely a good IOP control to a reasonable time period. So that is the way that we look at it. Regarding Dr. Girija's topic, probably I will kind of exclude the expression for time being, because only when it is going to be reintroduced, you may look at that. Otherwise, it is not going to be there. But MAGS and trabeculectomy, when to do, combined surgery, when to do, she has explained it very clear. And Dr. Jayashree has really explained it very well on the SLTs, and it's useful. George is really kind of very hard sitting here, and then he just wants to go now and start doing all the cases SLT immediately. And seems to be Dr. Girija as well. So thanks for your wonderful talk and convincing most of the people here to CKSR is going to buy the SLT machine from NIDAC today itself. Thank you all. I think if you want to add something, please.
Anybody has any doubts? The two great stalwarts are here, so can
I'm sorry, I didn't give you about your topics comments, because your topic is the most important topic. But if somebody is going to treat the non-glaucomatous eyes with all the whatever we have spoken, is going to be extremely poor decision making. So thanks for your wonderful talk. So your question is, where do you do the repeat trabeculectomy? The idea is, once you have done it nasal, you do it a little temporal. If you have done it temporal, you do it little nasal. That is the only way. But the concentration, how much is the blood fibrosis that you have seen in this previous surgery, based on that you can take some decision. If the conjunctiva was really loose and then the previous surgery was not much of a blood scarring, but in spite of that it has gone in for a failure, you can still do it with the 0.2 for a little longer duration. Or if the scar tissue formation is too high, you go with the 0.4 and then do the repeat trabeculectomy at a nasal or temporal, depending upon the previous first surgery. Okay. Any other questions that any of you have? This company fellows had come and told you that I'm using cyclosporine. I use cyclosporine because the simple reason is, one thing is, what you should not use is nepafinac. Post combined surgery or post trabeculectomy, please do not use nepafinac. That will cause lot of scar tissue formation, and it will go for ultimately it will go for failure. Cyclosporine, the reason to use is, one is the anti-inflammatory response which it gives, and second thing is the conjunctival goblet cells will be completely destroyed in these cases. So one is to stimulate this to have a better tear secretion, tear formation. So these are the two reasons. In my patients, I feel it is a bit more comfortable for me. So that is the reason why I use it. Because the post trabeculectomy eyes, many of us are not really looking at it. The dry eye syndrome or the ocular surface disease is quite high. Only thing is we are not asking for, or we are not even giving our ears to hear what they say. Once you have a lot of scar tissue formation, the conjunctival goblet cells are completely gone. So the tear production is going to be very, very less. So we have to give them a supplementary therapy of the tear substitutes, whatever the way you are. But I use very often I use Sequa or the Lifent or whatever. I don't use much of a Lifent. I use Sequa very often to make sure that the patients are more comfortable. Please do treat the patient's compliance. It is very important. We really don't hear them well actually. Okay, Judge.
Yeah, just one parting comment. Just one parting comment. Somewhere down the line, I think we have not been training our postgraduates in trabeculectomy. It's a very essential skill that all ophthalmologists should probably know. It is an yeah. That's what I was also thinking. How many teachers are here? Postgraduate teachers?
Madam, I know you are a teacher.
Yeah. Because during my post graduation, my seniors used to teach me trabeculectomy. Early in my career, also, I used to teach, but somewhere down the line, there's a lot of concentration on fellowship training. But I think trabeculectomy is an art which postgraduates need to know, and I hope it doesn't die down going forward with so much of mixed procedures coming in, because there are a certain group of patients that have to undergo trabeculectomy. You have a juvenile glaucoma, you can consider a GAT, but you should also be, and the technique is not very difficult, but it is not simple also. The main aim is to prevent hypotony doing trabeculectomy. Thank you.
The last word from the IC instructor.
I hope you have learned something from this session. Any more doubts? Okay, then we'll wind up the session and
Just one thing is like I usually see a bit more crowd in KSOS. I'm quite surprised myself and George. Probably it is just different locations, different floors, different halls. I think it is the reason. But usually the crowd is much higher usually in KSOS. Anyway, let's see how it goes tomorrow.
This looks like a TNOA crowd. I will request our chief instructor, Dr. Girija, to hand over a memento to the president of Glaucoma Society of India, Dr. Satyan.